We'll move to next session, that is table Viva on medications. Examiner will be Dr. Rupinder ma'am and Dr. Gaurang Kothari sir, and fellows will be Dr. Naurin Desi and Dr. Shilpa Ajit. Oh, ma'am, over to you. Thank you.
Yeah, yeah. So okay. So can the fellows please switch on their cameras? So we have Dr. Noreen, and who's the second fellow?
Shilpa.
Dr. Shilpa. Okay.
Hello, ma'am. Can you hear me?
Yeah, yeah.
Good afternoon, ma'am. Good afternoon, sir.
Good afternoon, ma'am.
Who's in darkness?
Ma'am,
You are in darkness. Okay.
think
So, okay. So let's start with local anesthetics. So, when I say the word local anesthetics, what do you understand by that, Dr. Shilpa?
and local anesthetics are basically drugs which are used to block nerve conductions. Basically, what we use for blocking pain generation pathways. So these are basically used to block the sodium channels, which are mainly concerned with the pain generations, ma'am.
Mm-hmm. So, how do they act basically? Can you just tell me a little about the mechanism of action of these drugs?
So local anesthetics, they bind mainly to the sodium channels which are present on the nerve fibers. So voltage gated sodium channel. So when a nerve when a pain stimulus is generated, the how the pain stimulus is generated is how, like, when an action potential is generated, the resting membrane potential is mainly minus 70 millivolts. So when an action potential is generated, there is a influx of sodium ions into intracellularly. So this reduces the negative. This reduces the. This increases the resting membrane potential, and this generates the action potential. So the local anesthetics basically block this action of this action potential generation.
So, in brief, it causes a reversible interruption of conduction of impulses in the peripheral nerves, and it causes a decrease in the rate and the degree of depolarization of the nerve membrane, right?
Yes, ma'am.
So you know something about the ionized and the non-ionized part of the local anesthetic?
The local anesthetics, the mechanism of action of local anesthetics, mainly pharmacodynamics and pharmacokinetics. So pharmacodynamics mainly depends, local anesthetic initially needs to get into the the nerve cell. So
Which is the active component, the ionized or the non-ionized?
the ionized form of the local anesthetic is a active component.
So that goes and binds to the receptors?
Yes, ma'am.
Okay. So what are the factors which affect the ionization, the percentage of ionized and non-ionized form?
The intracellular pH.
Okay, so number one is the pH of the medium into which the local anesthetic is going. Very good. What else?
Then the pKa of the local
Very
anesthetic.
good. Yes, yes. So what do you understand by the pKa of a drug?
pKa of the drug is basically the amount of the ionized form of the drug that is available in the medium. So the pKa of a local anesthetic is a little higher than the baseline pH of the medium. So pK is defined as the negative logarithm of the acid dissociation constant of the medium. So if the pK of the local anesthetic is close to the medium pH, then that means the local anesthetic will act faster. The onset of action is faster.
Okay. Dr. Gurang?
Yeah.
Yeah.
So Shilpa, as ma'am and you were discussing about the negatively charged and the unionized and the ionized form. So what is important? How basically does the drug enter to the sodium channel? Is it the ionized or the unionized form?
So so for the drug to enter into the cell, it should be non-ionized, and it should be so basically the local anesthetics are all lipophilic, so it should pass through the lipophilic membrane of the neuronal cell. So it should pass and it should be unionized, and then it enters into the neuronal cell, and then it breaks down into ionized and unionized form, and then the ionized form attaches to the open voltage gated sodium channel.
Okay. Okay. So when you're saying about the voltage gated sodium channel, can you tell what are the stages or what are the types of voltage gated or which forms they exist in?
The sodium channels basically exist in three forms, sir: open, activated, and inactivated forms. So the open forms are when the local anesthetics enter into the neuronal cell, and when the also when the sodium ions also enter into the cells, sir.
So basically, it needs an open sodium channel for the local anesthetic to enter and it to act. So Noreen, if you can pick up from there, what is ion trapping? Can you when we're discussing this, can you tell something about ion trapping? Are you aware in terms of local anesthetic? What is ion trapping?
Sir, as Dr. Shilpa has told that the ions are in two forms, the local anesthetic, that is unionized and ionized forms. So basically the unionized forms, that uncharged basis of local anesthetics, they enter the membranal sheath of the nerve tissue, of the nerve fibers. And once it has reached intracellularly in the nerve sheath, it gets converted into in the ionized form, that is the water soluble form, and through there it acts on the activated sodium channels. So the movement of the unionized form through the membranous sheath into ionized forms.
Ion trapping, basically, if you can explain in terms of placental transfer. So if a fetal has some of acidosis, okay, so the lignocaine will transfer across to the placenta, and because of the acidosis, it will be ionized, and there will be a trapping of the local anesthetic in the fetus, rather than so that is where the ion trapping you can explain in terms of the placental transfer. Okay, in terms when the fetal acidosis is present, so they will reabsorb, or the sodium or the local anesthetic will not be able to cross across from the placenta to the mother. So that is where the ion trapping you can explain.
Okay. So Noreen, what are the other factors which affect the potency of the local anesthetic?
Ma'am, lipid solubility.
Okay, so number one is, so what kind of lipids do the local anesthetics they bind?
Ma'am, in the sense,
Which lipid does it bind to? Anything specific? Shilpa?
I don't know.
So it's the alpha-1 acid glycoprotein.
protein.
Yes. So that is one where the bupivacaine or sensicaine kind of, it binds very actively. What other factors affect the potency of the drug? So one is lipid solubility, you said. What else?
Ma'am, the same plasma protein binding.
So the plasma protein binding. So what clinical implications do you have in a patient who is who has some hepatic diseases, or patient is
Or a neonate or an
or a
elderly.
neonate. Yes.
Or in patients who are malnourished or have any liver diseases, or patients of extreme ages, like Sir said, like infants or those who are very elderly. They have, sir, the protein content is less. They have less protein content, so there are less chances of protein binding of the local anesthetics. So as we know that local anesthetics binds to these proteins is like alpha-1 glycoprotein, and it potentiates its activity. I mean, the more it is bind to those proteins, the more for the more time it will be available for the nerve fibers. So if the protein content is less, so the unbound form of the local anesthetics will be more in the blood, and that will be easily absorbable. The less the proteins and the less the protein binding, the more unbound form will be available for the blood absorption and cause the toxicity of local anesthetic in such patients.
Okay, great. So, Shilpa, can you tell me what are the factors which affect the duration of action of a local anesthetic? And then we'll go on to specific local anesthetics. Can you just highlight a few points?
Ma'am, the addition of adjuvants, like epinephrine, sometimes if epinephrine,
I asked a very specific question. What affects the duration of action of the local anesthetic?
duration of action, the plasma protein binding of
What else? There are so many other factors, na?
the adjuvants added to the local
Okay, number
anesthetics.
2 is adjuvants. What else?
Then
What is the blood flow at the site where the local
the
anesthetic?
site of injection.
Yes,
Site of
very good.
injection.
Very good.
So the site of absorption, fastest absorption occurs at intrapleural, then is more than intercostal, then lumbar, epidural, brachial plexus, subcutaneous, and
So, in clinical practice, does this have a bearing on your on the side effects which can be created by local anesthetic?
yes, ma'am. Like if we depends on the vascularity of the area.
So, more vascular the area is, more will be the uptake of the drug, right?
Yes, ma'am.
That is how you determine the duration of action of the drug as such per se. Dr. Gulam?
Shilpa, we are discussing here. So, any other factors, patient factors, which you can think will determine the uptake and distribution of local anesthetic? Any cardiac factors?
Cardiac. Sir, if high overload state.
During, do
Yes,
you
sir.
any cardiac factors which will determine the uptake and distribution local anesthetic?
Sir, if the patient already has, sir, any cardiac abnormalities like the workload, the overload, and
So basically, anybody with low cardiac output.
cardiac output.
Okay, so the amide local anesthetics, they will require. They are dependent on hepatic first pass metabolism. So if somebody has a low cardiac output, the delivery to the liver reduces and the chance of toxicity increases. So that's it.
Okay, so Shilpa, can you just briefly classify the local anesthetics? How do you classify them?
Local anesthetics basically based on the pharmacology of the local anesthetics, they are divided mainly into ester local anesthetics and amides. Local anesthetics, the basic pharmacology.
What kind of local anesthetics are we using nowadays?
We use amide local anesthetics, ma'am.
Amides. Why aren't we using esters?
Esters have chances of allergic reactions,
Very good.
and
So yes, so there was high chances of hypersensitivity reaction with the esters, so that is why they are out now. So what we are using? We are using amide.
amide local anesthetic.
Right. So briefly, just give us the basic pharmacological chain. What is there?
Ma'am, local anesthetic basic pharmacological chain consists of an aromatic chain, an intermediate chain, and a tertiary amine.
Yes.
So the esters and amides are basically classified depending on this intermediate chain. So this intermediate chain, if it is an ester group, then it is an ester local amide, and if it is a amide group, it is an amide local anesthetic. And the amides are further divided into long acting and medium acting. Medium acting amides include lidocaine or lignocaine, and long acting include bupivacaine or ropivacaine. Esters include medium acting and long acting. I mean, short acting and long acting. Short acting include procaine, and long acting.
No, we will not discuss the esters because we are using amides. So, Dr. Guran, you can ask Noreen.
Noreen, just before we go on to the other things, we use the spinal. So, what is the concentration of dextrose that is available in the heavy bupivacaine that is there?
Sir, it is about 7.5% of dextrose, which makes it hyperbaric, like more the specific gravity.
And similarly, if we have commercially available lignocaine with adrenaline,
8%.
No, lignocaine with adrenaline. Okay, how much concentration of adrenaline is there per ml?
Sir, it is 5 micrograms
Yeah, so
per
this,
ml.
yeah, okay. So, ma'am, shall we go on to the intralipid
Yes,
now?
yes, yeah.
So, Shilpa, can you identify what is that and what is the constituent?
So this is an intralipid lipid emulsion IV, which is used for a local anesthetic systemic toxicity. It consists of 20% of soybean oil, 1.2% of egg lecithin, and 2.2% of glycerin, and it is available in 200 ml vials. And
Also available in 100 and 500.
100 and 500 ml vials.
So you said the triglycerides.
Right.
What are the short chain, medium chain, or long chain?
So this interlipid consists of long chain triglycerides containing linoleic acid, oleic acid, palmolic acid, and one more, sir.
Okay. So
Okay. Shilpa, how does this intralipid act?
Ma'am, there are different mechanisms of action which are postulated. So one is lipid sink, one is lipid shuttle, and it blocks the mitochondrial dysfunction which is caused by the local anesthetic. And
what do you understand by the lipid sink?
It displaces the bupivacaine from the cardiac sodium from the cardiac sodium channels, ma'am.
Mm-hmm. So what happens is this? Yeah. So what kind of toxicity is seen with bupivacaine?
Cardiotoxicity, ma'am.
Toxicity. And what about lignocaine?
Neurotoxicity.
The neurotoxicity. So what intralipid does is that it is a kind of a competitive binder. It goes and binds to the cardiac myocytes and tries to prevent the bupivacaine molecule into the cardiac myocytes However, it is very difficult once the bupivacaine molecules are attached to the cardiac myocytes. It is difficult for the intralipid actually to go and displace. So that is why the toxicity of bupivacaine, the AV blocks and the bradyarrhythmias which you have is very lethal with sensicane. And in fact, I don't know, till date, even I have not seen any patient kind of coming out if actually there is a bupivacaine toxicity if it occurs. What do you say, Dr. Gurang?
Yeah, ma'am. Thankfully, we have not had, but we have heard a few case reports. So,
Yeah.
so Noreen, briefly, if you could just talk about the symptoms of LAST and the treatment.
Yes, sir. So symptoms of LAST, as we know, it can cause local and systemic toxicity. So in systemic, the toxicity that it can cause is cardiac and the neurological. So the neurological symptoms toxicity is more sensitive. That is most likely to occur before the cardiotoxicity.
So, what is the first symptom the patient has when if a patient is having?
Ma'am, those are the early symptoms. In 40% of the cases of the LAST, we get the early symptom, that is prodromal symptoms, where it is perioral numbness, there is tongue paresthesia, they'll have this metallic taste and that tinnitus. So these are the early symptoms. After that, because the local anesthetic will causes inhibition of the inhibitory neurons, cortical neurons. So there'll be excitation, there'll be neurological symptoms like seizures, agitation. Uh, Patient can also land up to coma, and then eventually, if the toxicity reaches the higher level, so cardiotoxic symptoms will come into play and will get this conduction defects. Patient will have tachy or bradyarrhythmias. There'll be PR segment prolongation. Sometimes they can be even the sinus node will be blocked and the patient can go into cardiac arrest.
Okay. So, how do you manage it, Shilpa? Suppose, uh, have you seen last?
No,
Shilpa?
ma'am. I haven't seen, ma'am.
I have seen a few, and that was basically more common when long time back when we were giving IVRAs. There was when there was a sudden dysfunction of the tunicate. That was the time actually last did happen, and it was IV lignocaine which caused it. So how do you manage it? Okay.
Ma'am, as soon as we find out symptoms of LAS, we initially call for help first, stop the local anesthetic, whatever dose that we have given, and then we initiate the cardiopulmonary support, and then we call for the intralipid treatment. So intralipid, how we give it is, if depends on the weight of the patient. If it is if the patient is more than 70 kgs, we give an initial bolus of 100 ml over 2 to 3 minutes, and then later we give an infusion of 250 ml over 15 to 20 minutes. And if the patient is less than 70 kgs, we give an infusion of a bolus of 1.5 ml per kg, and then infusion of 0.25 ml per kg per minute. And if the symptoms and if the patient still has symptoms of LAS, then we can repeat the bolus, and we can repeat a maximum of 2 boluses, and we can repeat the infusion as well. Total dose, maximum total dose of up to 12 ml per kg. And if the patient has seizures, the recommended drug of choice is midazolam. And if the patient has arrhythmias, we can use amiodarone. Better to avoid beta blockers or calcium channel blockers because it can aggravate the cardiovascular instability. And And yeah, and once a patient is stabilized, it is better to we have to review the patient 2 hours after the if the patient had only seizures, we have to review the patient 2 hours later, and if the patient had a cardiovascular collapse, we should review the patient 4 to 6 hours, every 4 to 6 hours.
So what do you think? The duration of the CPR, is there any difference in the duration of CPR when there is a bupivacaine toxicity?
Yes, ma'am. Because there will be a cardiopulmonary arrest because of bupivacaine.
Yes, so CPR should be continued at least for 1 hour if you are suspecting bupivacaine toxicity.
Any changes in the dose of resuscitative drugs you want to consider?
Epinephrine should not be used. Should be used at a dose of less than 1 microgram per kg, sir.
Why is that?
Because it can trigger arrhythmias.
And
And
it also reduces your SVR increases.
SVR increases.
Yeah.
Right.
Okay. So we'll go on to the adjuvants. Nurin, what is the commonly used adjuvants you use at your center?
So at my center, we commonly use dexamethasone and sometimes dexmedetomidine.
This you are telling for peripheral nerve blocks.
Sorry, sir?
For peripheral nerve blocks.
Peripheral nerve blocks, yes, sir, mostly dexamethasone.
So how does dexamethasone act as when you give it as a adjuvant?
So basically, it potentiates the analgesic effect of the local anesthetics, as it has anti-inflammatory and anti-nociceptive properties, and it acts locally also on the nerve fibers, it causes the hyperpolarization of the nerve fibers, which will ultimately lead to decrease the nerve pain transmission across that neuronal fiber. So it potentiates the analgesic activity, and with its synergistic, it also increases the sensory motor block of the drug, sir, and and helps in decreasing the cumulative effect by not cumulating the local anesthetic.
Shilpa, central neuraxal blockade, which adjuvant do you use and how does it act? Briefly.
Sir, morphine, sir.
Yeah, so how does it act?
Sir, the gamma.
Which receptors it goes and acts?
I don't remember.
You're not sure? Okay.
G protein, sir, G protein coupled receptors.
Not sure? Okay, fine. Ma'am, I think our time is up.
Yeah, our time was up. In fact, Dr. Hetal?
Yeah, thank you, Rupinder ma'am. Thank you, Dr. Gaurang. And thanks to both the fellows. It is really difficult, toughest topic of the regional anesthesia, I will say, and it is nicely covered by both the mentors and the fellows. Thank you very much.